Thank you very much, and thank you for allowing me to present this presentation. I'm glad to be with you, and I hope this presentation will give you some enlightenment about your practice and to add to your practice. In this presentation, I will talk about how I rehabilitate extremely atrophied jaw without bone augmentation. It looks like it's a magic, but it is not. Let me just explain to you in this presentation. Um, First of all, allow me to present myself. I get my degree of dental surgery in 1999 and my postgraduate diploma in oral and maxillofacial surgery in Damascus in 1993. I get a Master of Research in Medicine and Biology, and in 2004, I get my PhD in Oral Sciences. I served as a course director of Master of Implant Dentistry, University of Warwick for 5 years. And a fellow of the Association of Dental and Facial Aesthetic. I served as the president of the scientific group in the International Association of Dental Research. For 3 years, I was a honorary research fellow in Montfort University in United Kingdom, and I get my postgraduate diploma in basal implantology in 2019. Actually, I'm practicing in France, in the city of Compiègne, which is north of Paris. It's a beautiful city where Napoleon III used to to stay rather than staying in Paris, and his guard, royal guard. This is a building of the royal guard where actually my practice is. Well, um, when I met my mentor, I call all Carl Misch, and we discussed a lot. That was 2009, 2008, I think, and I just discussed with him the problems with the sinus lifting, and I was really looking for a way to avoid sinus lifting because I felt that interfering with a space which is normally should be there. And the answer was there is no way. We need to have bone to place implant. There is no, we cannot place implant without bone. And he's right because without bone we cannot place implant, isn't it? But what bone? In fact, when you look at the after extraction or lose of a teeth, um, the alveolar bone, as we know, will fade away. And we can see here the resorption in the upper and lower mandible, in the mandible and the maxilla. And the alveolar bone will fade away because it's here to help the teeth, to support the teeth. And when there is no teeth, there's no need for it, and it will go. But what will stay, what we can see in the D, what will stay is what we call the basal bone. And this is a bone, isn't it? And the basal bone is something that if we have the right materials, we can use it to rehabilitate. And that is the point of my presentation today, is to show you how to use this basal bone to place implants without needing to recreate the alveolar bone that we lose after the tooth extraction. Um, we know that well, I'm not going this part. I will go fast on it, but we know that when we have this huge and large resorption, um, we can either do the FP1 way of rehabilitation, where when we recreate bone, or we can do FP3, where we can replace the lost gum or the lost gingiva by this by the resign in this case. Um, Also, when we have the management of the division B, where we have I wanted just to go before going to the basal implant. I wanted to show you what I used to do, and that things I think most of you are continuing to do it by using non-resolvable membrane. I started doing this because what we have been told that it will get, because it's not resorbable, we will get the mass of bone preserved that we place. Um, and it's indeed it works. I'm not saying nothing. Just to make it clear, I'm not saying it doesn't work. I'm not saying that if you recreate bone, you do bone augmentation, that it's wrong. It's not wrong. It's another way to give the patient what he wants. I'm just trying to show you how I do it. With the resorbable membrane, that works, and indeed I get good results. But the fact that the patient needs sometimes to do two surgeries was something that will refrain. For me, it was a problem because I always like simplicity. I always try to find simple solutions. Um, I start using resorbable bone, and as you can imagine, I didn't get good results with it. Um, but of course, it still works. Okay, I'm not saying it doesn't work, resorbable bone, but I was losing some of the the bone I'm placing, and I'm adding to the um, to the site. I start using also something like osteosynthesis plate. These are a plate which will push the membrane, the membrane away far, so which create some spacement where you can place your bone grafting materials, and um, I get good results with that. But sometimes we have issues like sometimes I get this plate or the metal exposed under uh, the membrane. I can see it in the gingiva. I can see sometimes this metal exposed when I trying to get a lot of space by adding the bone. Um, Here's another way to get vertical augmentation around the implant. Well, I place the implant in the right depth, and then I try with by putting the metal this way, the osteosynthesis plate, by putting them this way, we can create another time. We can create this space where we can compact the grafting materials. You can see here panoramic of the osteosynthesis plate used. Of course, what we called Huri method, we get the bone from the ramus or the chin, the autograft, and we all know that with autograft we get very, very good results. Um, but always for me the problem was the patient suffering, because doing two surgical interventions at the same time on the reception side and the donor side, it was really traumatizing for the patients, and it was a really experience that they won't repeat it again. Here we can see how we can get from the ramus the cortical plates, and we can use it for either for vertical inlay autogenous, where we can compact it between two pieces of bone, or onlay, where we can add it to the surface, to the cortical bone. Sinus lifting, I'm just summarizing what is practiced, and then we get to the point. Crystal, we can have, of course, we all know that sinus lifting, we can do it either by crystal access summers, and there is more problems associated with this method than the side windows, which I advise personally. If you want to do bone augmentation by sinus lift, I would say I would use Tatum's method, the side window, rather than the summers, where you cannot see what's going on. Anyway, this is personal opinion. Sinus lift, here's a sinus lift which where we can add, you can see opening the window. I used to detach the window, I don't keep it on the side. And then the membrane, we can lift it. The window, I do it with bezo surgery, so you're already in the safe side. The synthetic bone grafting, and then closing, and we can get, I used to get good results, but yeah, still this is a problem with the patients. We can see the healed, as you can see here, we can see the healed area, and we still can see the membrane of the sinus, which is a little bit more thick in this side from the other side, which means that we did get some intervention, traumatism, which get to the sinus. Here is the initial situation of the case we found, and there's 6 months later. And then we can place the implants. And the reason I'm showing you this case, just because in this case, the implant in the middle has failed. The patient came to me 3 years afterwards, and the implant, which you understand, the implant which is situated in the bone grafting materials, it has failed. And I noticed that even when I'm doing a good sinus lift, the percentage of the failed implant is more important in this, when we are placing the implant in newly created bone, than when it's created in the native bone. And this is what I noticed, and that's why I, in addition, decided to stop sinus lifting. My last sinus lift was done in 2010, and in addition to what I told you, we can see the hemorrhage, the infection. Sometimes we get oronasal fistula. Sometimes the ostium is blocked. And of course, this is a case which came with ambulance migration later on, because if it fails, sometimes it doesn't fall in the mouth, it goes just in the sinus. So for all this reason, I tried to find some way, another way, and alternatives. Zygomatic implant was my first alternative, which I tried to do. And with this alternative, zygomatic implant, I made a course in Spain, and then I placed my first zygomatic implant. That was 2011. And as you understand, the zygomatic implant is placed in the zygomatic bone, which is a very, very hard bone, and we get very, very good results, very good retention. The problem, as you can imagine, it's very, very invasive. We are talking about the sinus lift and preserving the sinus. You can see here that the sinus You can see that we are practically invading the sinus here. Um, Also, I get the problems I will show you later on, and I did only two zygomatic implants actually. Um, the problem also which we get with the zygomatic implants, it has a higher cost. The price at least 70% more with the zygomatic implant than the conventional treatment, and it can used only for fixed prosthetic rehabilitation and the complications. And let me show you. Here are some list of complications that we can find. Sinusitis, of course. Sometimes we get implant failure, but really it was done failure. It's rare to get it, but when it's get an implant failure of zygomatic implant, it's very, very, very difficult to manage. Sometimes you get a perforation of the orbit, and it's very, very serious situation. But that's why you need to really planify your interventions. And cutaneous fistula, something that I experienced with one of my patients myself, and I'll show you the case. Sometimes you get paresthesia because you are too close to the infraorbital nerves, and of course the inflammation of gingival and peri-implant soft tissues. Here's a case I'm talking about. I place this zygomatic implants. This patient, as you can see, she has a traumatic maxilla, and we talked about zygomatic implants, and we placed two zygomatic implants with two pterygoidian implants and two central implants. The placement was great. Patients was very, very happy. Everything gone well. Just she came after 1 month, I guess, and we had this problem. Um, uh, as you can see, there were perforation of the zygoma by the zygomatic implant. This perforation um, can happen because you didn't measure the depth. It's really matter of some, you know, less than 1 millimeter. To get the zygomatic implant for that, so we didn't place it, you need to be in the cortical bone. So you need really to stop in the cortical bone. And with just 1 millimeter more deeper, you get this perforation. So it's really very, very, very uh, important that you get this done well. And in that case, I guess I did a good planification, and still I had this problem. This problem can be managed by grafting the zygoma defect, and you can see that it's something that can be repaired. Uh, we have the other alternative, which is angled implants. It is, yeah, as you can see here, all-on-4 concept. And the idea of the angled implant, like the all-on-4, is to get the implant mesially to the sinus with an angle, or distal to the sinus, or you get it vestibular or palatal. It's just to avoid the sinus. But as you can see in this cases, that you will get an implant which is not in the right position for prosthetic position, which will make very complex the realization of the prosthesis and also the cleaning around this implant and the hygiene procedures. Um, the advantage that you have less invasive surgery with no sinus lift. So if you can avoid it, you can. It is something that is an advantage for the patient. To overcome the problem related to the angled implant, Victory from France has developed what we called oblique implant, and you can see that the prosthetic connection is made in a way that it will be parallel to the gum when it's placed with an angle. So you can do your prosthesis easily, and it can be the hygiene around this implant will be well managed. But still, you need to have an angle which is corresponding to this angle of approximate angle which is made with which this implant is made, and you still might find yourself with the same problems you find with normal implants. Here's a case with the oblique implant, and as you can see, this allow with a pterygoidian implant to avoid sinus lifting, and you can do immediate loading to this case. Short implants is an alternative. As you can see here, we can use short implants to avoid sinus lifting or to avoid displacement of the mandibular nerve. The short implants can go now until 5 millimeters. You have good quality implants, which makes 5 millimeters. The advantage that you have no complicated bone procedures, you spare sensitive area and structures, and you reduce the treatment cost and the time of the treatment. The disadvantage of this is that when you do it, the hygiene around the implant is complex. And the other problem is that when it gets some peri-implantitis, you have really no time to act and to save the implants because it's short implants, infection or peri-implantitis get very fast, and the mobility you get it very, very fast. This is to show you why it's complex to get a good hygiene procedures around the short implants, because we have the ratio of the crown not in the normal ratio, which create a huge profile emergence. The profile of the crown is very complex and create a lot of space around it, and which is very difficult to clean. Pterygoidian implants, it's very, very really, I like this implant because when you place it well, you have very good anchorage, and the implant is really in the cortical bone. The pterygoid implants is placed in the pterygoid bone, in the descending L's. Here we can see it on the both sides, and it's when you place it, you are placing it in a zone where there is no major structures that can be damaged. This is a presentation of the cortical, pterygoidian implant, show you where it's placed exactly. Just to let you know that it's not with this long length that we place it. We are not going that far, but it just to show, this is a presentation to show where the implant is placed. Another presentation, and as you can see, there are some angulation to get after the tuberculous bone, and to get this implant into the pterygoidian bone. It's not easy to do the procedures on these implants because there are some angulations, but it's really giving a very, very good stability to all your prostheses when you are placing it. Here a case of pterygoidian implant. The patient didn't wish to have bone sinus lifting, and I get cortical implants placed and pterygoidean implant and a classic implant in the front. You can see here how the pterygoidean implant is placed in the pterygoidean bone. And as I told you, you can see that the screw is accessibility of the screw is somehow a little bit complicated, but the patients get her fixed prosthesis, and it was very happy because there was no need to do any major surgery, just placing the implants, and we go. Another one, we can see the pterygoidean implant, which is avoiding here in that case the sinus lift, as you can see. Disc implants, it's a special type of implants. The advantage of the disc implant, when you don't have enough width of the ridge, and in that case the implant is placed from the side. It's not an implant that you will place it like a screw. It's an implant that you need to cut from the side of the ridge and insert it, so that the base of the disc implant is in the cortical bone, so that the occlusion, the masticatory forces, is transmitted to the cortical bone. Here we can see the disc that is used to prepare. You know, as you can see here, we just try to get from the side of the ridge with this tool, which will prepare the placement of the disc implant, which is, and afterwards, which is impacted in the area we prepared. The advantage of this implant is that even if you don't have enough width of the ridge, you can place it, and you add you can add the bone grafting. Here's a case where we have that's what I told you about the width of the ridge. We can see a knife ridge, and if you want to place an implant in this ridge, of course you cannot do it. It's impossible, because you need at least 5 millimeters, and you don't have them here. So you need to do bone augmentation procedures to get to the 5 millimeter, or you may use the disc implant, as you can see, with a membrane and bone grafting. The advantages of the disc implant, that these shelves, it acts like a shelves, which will where you get your bone grafting materials impacted here, and it will stay here because it's like a shelf, which will get it fixed in this area, and then you get bone formation around it. But the implant will be fixed, and the patients won't have to wait 6 to 9 months until the bone is formed. You can do immediate loading to these implants, because once it's really fixed, you can immediately place immediate loading, which is better than waiting until the implant has integrated, because the axis of the implants might get with the integration outside the ideal axe, while when you are putting immediate loading, the implants will be integrating in the right axe, and there is no screw under some pressure or some forces, because it's not in the right axe comparing to other implants. You can see here that this is after 6 months, and you can see that bone in the same ridge you have seen in the first slide. The bone has been formed around this implant. Here's another case where The patient had suffered several operations of bone augmentation in the area of the, and several times he failed to place an implant. Two implants were placed by my colleague, and it was failed. And so I used disc implant. This helped me to resolve the problem associated with this patient. Another case where I had a ridge, knife ridge, and again with this implant, by preparing and placing this implant, you can see it in the picture on the left, and you can see the preparation in the picture to your right. We managed to get this implant placed, and you can see the bone graft around the implant, and this patient had hair prosthesis 3 months later. This is a case I showed you when I told you that I resolved with the patient who had several failures, and the reason for that, you can see that sometimes you need to think. You can see the why we have the failure. He failed twice, and some of my colleagues tried to make bone augmentation, and even bone augmentation procedures, we still get no bone formed in the area. And uh, we didn't understand why, but I believe that it's because we have impacted canine in the area, and as we can know, the bone is irrigation is made by infiltration, and the fact that we have this area breathed from the arrival of the blood from surrounding area, because there is um, this impacted canine blocking any access of blood to this area. Uh, we were found always with this few centimeters of bone, but we'll never be able, even with the Curie method. One of my colleagues get bone grafting here with look at the bone in the ramus, and so we have always 2 to 3 millimeters. So I said, okay, let's try the disc implant, and actually you can see here that I just cut under the canine, and I placed the implant, the disc implant with the bone grafting, and I closed it, and the patient get his we managed to get him this implant integrated. And I'm sorry, I couldn't find the picture of prosthesis. Maybe next presentation I'll manage to get it to you. Cortical plates is a way of using, and thanks for my colleague, my dear friend Henry Dietrich, who um, presented this method to me. And this is where we this basal implantology concept in my head, that yeah, let's use the existing bone, exactly like this implant before, as you have seen, opteroidean implant. In fact, we are using a bone which will never fade, which will be always there. And the concept, as you can see here, basal bone is always there, and even if you have a resorbed mandible or maxilla, you still can place this cortical plate with needed with the screws, and fix it with the screws. And this cortical plate, this is a screw which is also treated, so can integrate with the bone. So here's a case of extremely atrophied maxilla, and we use the plate, as you can see. The idea is to put the plate in the canine pillar, in the zygomatic pillar, and with an implant in the pterygoidian area, and then you get like these three pillars uh, rehabilitated. You can restored, sorry, you can place your prosthesis, fixed prosthesis, on these three pillars on each side, six pillars. And here we go. You can see the pterygoidian implants, the geometric pillar, and the canine pillar, and then you can rehabilitate the jaw. Here's a case of an extremely atrophied key, and I will stop here. Sorry for the length of my presentation, but I really wanted you to want to show you the maximum of basal implantology and how can be help us to resolve problems for our patients. We can see this patient who is a female with 71 year old. She has a very good health conditions. She doesn't smoke, and she came because she's done with. She had all complete prostheses, removable prostheses in the mandible, and as you can see, she has no ridge at all. So it won't work, of course. And some of the colleagues proposed to her to use locators so it can fix it, and it's a huge mistake because you cannot use locators when you don't have enough ridge behind. Just make sure locators won't resolve your problems if you don't have a ridge to fix, because it's this type of prosthesis, the locator will not give all the fixation. You need to have some tissue support, and if you don't have tissue support, you cannot count on the locators. And of course, she ended up breaking two implants, disintegrating two implants. As you can see here, we can see the female parts of locators, and we can see two implants placed in this area. You can see how much thick her tissues because the two implants which was placed by a colleague in the center were very high, the distance until he get to the surface of the gingiva. You can see if we track the nerve that we have, really we don't have at 2 or 3 millimeters, and sometimes we get into the right to the left side of the patient. We can see that it's on the surface. The nerve is almost on the surface. The treatment plan was for her to use um, cortical plates. You can see the cortical plates preparation to get to the form of the mandible, and then we expose the mandible, placed the cortical plates and fixed with screws, and then we put bone grafting materials, synthetic, and we close. And here's the results on the both sides. We put two cortical plates. I left the two implants because they were integrated, and because if I try to move them, I might get the jaw broken. There are not really no bone left, so I left them. They were well integrated, and I used them in my final prosthesis. I added a third one to get some balance on the left and the right side. You can see the three implants with the two cortical plates, and just to show you how much the cortical plates in here is far from the nerve. Another image, you can see how much such intervention need to be planified. The screw is really 2 millimeters from the nerve. So you need really to know where you are placing also your screw. Here we go. And always in that cases, when I do cortical place, I do immediate loading. So a few days afterwards, the patients came back and the final prosthesis was prepared. And here's the results, and the patient was happy because the options, the treatment plans were presented to her, included the parietal bone grafting to look for the bone in the skull, etc. So, and we can see here the presentation. So, take a home message. I'm not saying that what is done is wrong. I'm not saying that bone augmentation is wrong. I'm just saying that all the way get to Rome. And if you can do it in a simple way, I prefer it myself. I prefer simple, fast way rather than getting the patient severe intervention to get to what he wants. The patient came to us because he wants a teeth. The patient doesn't care how you get him this teeth. He just wants a teeth with which he can eat with no problem. If you get him this by doing basal implantology, why not? If you want to do it other way, why not? It just, there's several way to get this lamp, the light switch on. Just you don't have, you might decide to use a longer complicated wire, or you use direct wire. It's up to you. From my perspective, my point of view, the best treatment plan is which is lined this way between effectiveness and simplicity. You might get a great effectiveness, but if you are not simple, the patient will suffer. You might be very simple, but if you are not effective enough, the patient will not happy. So if you can get this equation, this is where you go to in the right direction. To read more about basal implantology, my mentor, my dear Dr. Scorchi, he had a book about it, and if you want to go further about basal implantology, I invite you to read it. And as I told you, it just as said Abraham Maslow, if the only tool you have is a hammer, you tend to see every problem as a nail. I'm not exclusive to any implant system. You can see this patient. I always show this patient because she had ceramic implants. I place ceramic implants in the aesthetic zone. She has a cortical plate on the left mandible. She had short implants on the right mandible, and she has classic implants on the right maxilla now. So as you can see, just adapt to what the patients need. Thank you for your attention, and sorry if I was a little bit long. Here's my contact details. You might send me an email if you want more about this presentation. You can find me on WhatsApp on this number. Thank you very much. I will get back to my dear friend Basim and let him close this presentation. Thank you very much.